Hello everyone. It is my privilege to talk to you regarding updation of hypertension guidelines. The American Heart Association started publishing guidelines for hypertension since 2014. The last update was in 2017, where definition of hypertension was lowered to more than 130 by more than 80. Let us recapitulate the 2021 guideline, which defines normal blood pressure as less than 120 systolic by less than 180 diastolic. Elevated blood pressure as 120 to 129 systolic by less than 80 diastolic. Stage 1 hypertension as 130 to 139 systolic by 80 to 89 diastolic. When stage 2 hypertension is anything above or equal to 140 by 90. In 2021, American Heart Association released again guideline for management of stage 1 hypertension with low atherosclerotic cardiovascular risk. Low risk people with 10 years CVD risk less than 10% should be on lifestyle modification. If blood pressure goal is not met in 3 to 6 months, consider initiation of pharmacotherapy. But if their 10-year CVD risk is more than equal to 10%, both lifestyle modification and pharmacotherapy should be initiated. Reassess in 1 month. If BP goal is achieved, advise for follow-up every 3 to 6. But if not, then check adherence and do escalation as required. Protocol is same for stage 2 hypertension. JNC7 covered not only hypertension treatment but hypertension definition, issues in blood pressure measurement. It was based on consensus. In contrast, JNC8 focuses narrowly on treatment part and definition. It is mainly based on evidences from randomized control trials. Two specific differences are there. Number one, JNC7 fixed a treatment threshold for 140 by 90, irrespective of age, whereas JNC8 raises it to 150 by 90 for above 60 years aged people. Also, JNC7 recommended a lower threshold for diabetic and CKD patient, but JNC8 does not. Number two, in JNC7, 5 drugs were there in the list of initial therapy with preference to thiazides, but in JNC8, beta blocker has been omitted from that list. Two classes are there for black patients avoiding ACE or ARB unless there is associated CKD. Although there are 3 strategies for initiation of therapy, but the combination therapy in most cases works better in terms of potential, patient adherence, and cost. Never to co-prescribe ACE and ARB. Having hypertension puts you at risk for heart disease and stroke, which are the leading cause of death. But only 24% with hypertension have their blood pressure under control. That's why judicious use of hypertensives as per guideline and timely follow-up are so important. Thank you, Lupin, for arranging this academic presentation.